Good afternoon, everybody. I'm glad to have the opportunity to speak today to this wonderful audience. As a word of introduction, we are celebrating Women's Health International Day, which is a wonderful opportunity to talk about maternal cardiac health and how to improve outcomes and look into the lifelong cardiovascular care. I'm Catherine Bianco. I'm a maternal fetal medicine and medical geneticist. I work under the Department of OBGYN and Maternal Fetal Medicine Division, and I oversee the maternal cardiac disease program for the Stanford hospitals. We have a very, I, I would say, a lengthy conversation today, and I'm going to try to cover a lot of part of the topic, but I will be taking some pause here and there. So if anybody have questions, I'm happy to go over so we can make it interactive. One quote I really like about John Nash is the only thing greater than the power of the mind is the courage of the heart. I'm passionately interested to understand our physiology and more when related to the maternal cardiac field. In our outlines, we really want to look at the stage of maternal cardiac disorders and the maternal mortality as occurrent in the country and internationally. I like to talk about the risk factors and the pregnancy cardiac physiology just to put it into context. And what do we have there as a clinicians that we can use as a data point? Thinking about clinical evaluations and how we can use readily available cardiac scores applied in pregnancy. Multidisciplinary approach is something that we really want to emphasize in our clinical time. And since we have this opportunity at Stanford to have a multidisciplinary program, I want to show you our experience and how we approach this type of high-risk pregnancies. I also want to highlight the other part of the maternal baby diet, that is our neonatal outcomes, and how we have been also seeing that can be impacted through the maternal cardiac disorders during pregnancy. And lastly, I want to close with planning the future, thinking about contraceptions for this type of population, preconception assessments, and how we can start already elaborating how we're going to help these patients to prolong lifespan now they have decided to embark in creating a family. Further ado, let's just talk about what is the definition for maternal mortality rate. And I want to make sure we understand it clearly because that will help you to really dissect out in the literature what is the meaning. So overall, we know the number of women who die from pregnancy-related causes within 42 days postpartum divided by the number of live births in that year multiplied by 100,000. Then we'll see pregnancy-associated deaths, which is very important. When we look at death of women within 1 year postpartum from any cause, but you really want to make sure that when we look at the literature, are these pregnancy-related deaths or these are not pregnancy-related? An accident is not going to be related to the pregnancy if we would just use it as an example. This is just a heat map that you can see from the Center of Disease Dynamics and Economic Policy how the maternal mortality looks in the 2020s. And the intensity, as you can see, it will reflect more towards your maternity rate, starting from 3 to 1,000 to 300, which we know in some areas in Africa, like Sudan and those, have the highest maternal mortality. Looking in this graphic, you can see how in the developing countries, we have seen the maternity mortality rate has decreased to single digit. However, in the United States, we have an epidemic where our maternal mortality is growing and is going at higher rates to double digits and to be compared to Afghanistan and Sudan, which we really have raise our eyebrows. That's part of the reason we're having this webinar, and that's why we have put in a lot of effort, research, and money to trying to improve that. When we really look at specifically in the state of California, which we are super lucky as we have this collaborative effort to really look into the California birth and death certificates, you can see here in blue how California understood around 2000, early 2000, that we were having an issue with the rise in the maternal mortality. And it went to work, and it got, and I was explaining a little bit how this happened to really understand why we were losing these mothers. And you can see how the trajectory is going down, as you can see, compared with the United States rates that goes up. So if you put it in context from 1900 to the beginning of the century, major interventions in maternal care really changed the maternity mortality. The introduction of magnesium sulfate when patients develop preeclampsia and seize and die really decreased the maternity mortality. And then the introduction of antibiotics really helped to plumb this maternal mortality. So why are we having these issues these days? So we know now in our country, higher income countries, cardiovascular disorders and cardiomyopathies are becoming a quarter, 1 in 4 of the mothers dead, due to the fact of many risk factors I'm going to go over. We still have infections and venous thrombosis emboli and hypertension disorders, but really what is leading in these days is cardiovascular affection. When we look at this pie representation, you can see how a big representation is cardiovascular disorder for maternal. Our future in one of the journals in the New York Times is looking at early 2018 when a major study looked at maternal deaths in inner city population. I use big data, if you use it, to really look at the impact of maternal mortality. And one of the things that we learned was that comorbidities associated to mothers during pregnancy will increase the chances to have complications and death. And such as those were gestational diabetes, preeclampsia, and that was related with delaying childbirth, so increasing in maternal age, increased BMI, and carrying comorbidities during pregnancy. So they specifically looked at the increased risk for heart attacks, and this really was a good call to start investigating more. So stages of maternal cardiac conditions and contribution to maternal mortality, as I well explained and illustrated in CDC, it really calls for cardiac conditions, research, education, and mitigations. But also lately, we have been putting our DEI lenses to really understand, is there also other factors? And disparities in pregnancy have been another area that is being called for more investigation. There has been called that dependent in the variety of the United States population and where these patients are delivered, we had seen different rates of maternal mortality, but also ethnically. So as you can see here in the slide, the increase in mortality was most pronounced in non-Hispanic Black, where ratios were as high as 39 to 49 for 100,000 live births. So calling for, can this be structural, institutional, and systemic barriers to healthcare? We really need to look at the social determinant of health to really understand how this can play a role in maternal mortality. In California, we have the mechanism to collaborate with the Public Health Department through the California Maternal Quality Care Collaborative, the CMQCC. In particular, I would say we were very fortunate when we start seeing the rates of maternity mortality in the state of California, that we are going to do an audit and we are going to understand why we're losing these mothers. So expert review, look at medical records, they look at pregnancy-related, they determine the causes dead, they determine if it was preventable, they look at the risk level of the prenatal care and labor and delivery, they assess for patient, facility, and healthcare providers contributing to the death, and look for opportunity to really improve the quality in maternity care. Just to show you a few numbers of all this effort, the California Committee, it looked about 333 deaths related to pregnancy, and it was really enlightening to see how cardiovascular disease and leading by cardiomyopathies was such a representation, followed by hypertension disorder and postpartum hemorrhage. So this really helped to understand where was the root cause of this maternity mortality spike. And things that we were able to identify was like a lot of the deaths happened soon after delivery. Patients came to the emergency room or the hospital with complaints, and some identifiable factors were missed. Over a third of the dead had a good to strong chance to have an altered fetal fatal outcome, meaning that were preventable. Cardiovascular disease and cardiomyopathies combined accounted for more than a quarter of all these dead. And as I explained it, the common ones like an infection, VTs, and hypertension, so they were there, but they did not account as such. So I want to pause here and say, now that I state the problem and how it looks international and actually locally in our state, we really want to understand what are the risk factors and how the basic physiology of the cardiovascular system is affected during pregnancy. So let's look at this. If you think about it, as I've been telling you, cardiovascular is the most common cause of death during pregnancy. And moreover, if these patients have congenital heart disorders, which we have seen, now our mothers are born with this condition, they got surgery, and they got amazing care to make it to reproductive age, and now they want to start a family. They also are now in the category of high risk for maternal mortality and morbidity. If we put it in a schematic way, everything leads to heart failure in pregnancy and then the subsequent death. And so what are the things published by the American Heart Association lately? You want to look at cardiomyopathy, and cardiomyopathy can have many entities. It could be peripartum cardiomyopathy, hypertensive or not. It could be dilated. It could be idiopathic cardiomyopathy, but it could be also inherited cardiomyopathies, hypertrophic cardiomyopathies, no compaction, myocarditis, chemo-related, HIV, and also Chagas disorder, which is less frequent. The other type of disorders we see is congenital heart disorders. So the most common things in pregnancy in patients that have cardiovascular affection we're published on is arrhythmias, SVTs, VTACs, all kind of blocks, heart blocker. But we also have to think about valvulopathies, any abnormality in any of mitral stenosis, aortic stenosis, mitral regurgitation, aorta regurgitation, about any evidence of pulmonary hypertension, and lately is any ischemia or chronic ischemia disorder. So other things that you want to consider are race and ethnicity and social determinant of health. We want to make sure we can look at missed opportunities. Can we improve before pregnancy the course of complication? So looking at structure and cystectomy reasons, how impacts health disparity in cardiac disease can be a way to mitigate this. And these have been shown and published in many publications through American College of Obstetrics and Gynecology, excuse me. So age, we have seen how women are delaying the age to bear in pregnancy. So women over 40 years are shown to have 30 times higher risk to have complication as compared to counterparts, let's say 20 years old. If we look at hypertension disorder, overall, they complicate pregnancy about 10% in just normal health and pregnancy. That increased about 13-fold in cardiovascular affected pregnancy. And of course, we have an issue with obesity in this country, and it contributes to this. How about we look at the physiology? So as we think about it, different indicators of cardiac physiology, we can apply that in pregnancy, and we can see what is expected. Here in this chart, you can see your heart rate versus your gestational age in weeks, pre-pregnancy all the way to the postpartum period. And what you can see is what is expected. What do we know by physiology? What we expect and how the heart, the circulatory system adjusts to pregnancy. So we know the heart rate is going to increase about 15 to 10% in the third trimester. Very early in pregnancy, we start seeing changes in cardiovascular demands. I like to say, like, pregnancy is a beautiful stress test for the heart. Heart rate continue to go up 40 to 50% during uterine contractions. Then it drops dramatically 5 to 10% within 24 hours to the delivery. And it takes about 3 to 6 months to really be back to pre-pregnancy values. Some people say it takes up to a year to really recover from pregnancy. How about cardio output? You can see here our table physiology, cardio output versus gestational age, and you can see here by different time of pregnancy. First trimester, second trimester, third trimester, stage 1 of labor, just early labor, stage 2 of labor when we're actually actively pushing Valsalma, having a baby, early postpartum, which is a dramatic change within minutes. The mother has to really adjust her cardiovascular system to this, not being pregnant, changes in all the physiology as that you can see. 6 to 80% in early postpartum, you will see the changes, a rapid decrease in the cardio output, and then will return slowly in 3 to 6 months. So if you think about it, what happened to stroke volume? Similar. The left ventricle stroke volume across pregnancy in 12 weeks postpartum is illustrated here, and you can see the variability and how this stroke volume is so sensitive to patient position and why. Think about an uterine gravida, how it's compressing those major vessels, your veins and your artery and your aorta, and how just displacing the gravity in utero out from these major vessels can really change your stroke volume. Here in this table, you can see your first trimester, second trimester, and third trimester. But you also can see the early stages of labor, and at the time of birth, second stage of labor. And what happened immediately, just minutes to hours after delivery. So put it in context, we have a state dramatically going up on demands and all these different values. By the second trimester, the max demand is being achieved. We're able to have a plateau time in the third trimester, and then it comes back to the stages of labor, where mom really have to go through the process of labor, delivery, push the baby, Valsalva, and we can see how during contractions, it can really increase your blood pressure and your cardiac output. And then dramatically goes down after postpartum within 24 hours, but asking your cardiac output to go even higher, 60 to 80% immediately, because you just deliver it and you get this auto transfusion of 500 mLs. That increases your plasma volume, and that's going to increase your cardiac output. But at the same time, your heart rate and your blood pressure goes down as we're not pregnant anymore. If you see it in a graphic putting together pregnancy, labor, and early postpartum, you can see here, we look at pregnancy, your cardiac output, your heart rate, your systemic volume, your plasma volume, your left ventricle dimensions go up, but your systemic pressures and your blood pressures go down. When you look at labor, similar tendency, your cardiac output, your preload, your sympathetic stimulation goes up. In early postpartum, we just had the baby, we see how your cardiac output goes down as your systemic vascular resistance goes up and BNP goes up. So when we have to evaluate these patients, normally versus cardiac disease, there are a few things that you really can use as a lead to sort of understand what is normal and what is not normal in pregnancy. We tend to say, oh, pregnancy will give you shortness of breath. Oh, pregnancy will give you back pain. Oh, pregnancy will get you tired. But you really, in this high-risk population, you don't want to write it off. So patient complaints of dyspnea, symptoms related to physiology changes of pregnancy, could be also not normal. It could be pulmonary edema, okay? Peripheral edema could be heart failure. Mild tachycardia could be leading to an arrhythmia or compensation of a mild heart failure. Systolic murmur, you really want to investigate. And any dystolic murmur should be investigated. So definitely not normal to see chest pain, progressive exertional dyspnea, difficulty with active daily living, not good to have any hemolysis or anything like that. I like to call it red flags when we are evaluating pregnant postpartum patients, let's say in the emergency room, let's say labor and delivery, or even in the outpatient setting. Shortness of breath at rest, that's not normal. Patient really needed to grab a lot of pillows to be okay and not and be out of breath. Heart rate over 120. I know when we're not pregnant, we're okay, but when you're pregnant, that is quite high. Resting systolic over 160. Resting respiratory over 30. Oxygen saturation less than 94, I remember. That's not okay. That should prompt evaluation in acute in the hospital. Should be consultation by a maternal fetal medicine, primary care cardiologist. Somebody has history of cardiovascular disorder, but that not necessarily has any red flag, should have a consultation with the team. So this biomarker, I want to emphasize the importance of looking at BNP. It really is a neurohormone that it really help us to understand how the cardiac ventricles are responding to ventricle volume. If we start seeing high levels of BNP, we start wondering if we're seeing some element of cardiac dysfunction failure. So we use it for dilated cardiovascular or for anything that calls for left ventricle function, with shortness of breath, or any predictor of cardiovascular outcome in congenital heart disorders with higher BNP can be associated with poor outcomes, being well studied. So what about looking at other things? Dyspnea, postpartum dyspnea, a new onset of cough is concerned with cardiovascular disorders. And things that we learned through this audit in the California effort was that people who have this new onset of asthma will be treated with inhaler and it will be even getting better. I can emphasize that these patients really presenting for in the emergency room or in the postpartum visit complaining of cough and asthma might be just early signs of CHF. For those, needs to be investigated. What workup is easy and something that we really want to have it in our decision is a tree is like looking at chest pain, looking at troponin tests, looking at electrocardiograms. But we also can be objective and look at scores that can help us with cardiac assessment. And it's been very well studied in early 2000. This group of patients were observed through a long time period through the CardPreg initiative, looking at cardiovascular disorders in pregnancy. And they established a risk score looking at prior history cardiac event or arrhythmia, New York function class 2, looking at any cyanosis, looking at left heart obstruction, looking at systemic ventricular dysfunction. And that will give you a score of how severe is the condition of the pregnancy and complication with cardiac disorder. They were followed through a period of time that it actually was able to have a subsequent addition of more patients to these maternal cardiac events. Up to 1,900 patients were studied, and they participated a big chunk of patients that had heart disorders that were born with congenital, but they also had arrhythmias and they also have acquired. And as you can see here, this was the different things that they saw as a high-risk cardiac lesions that could lead to severe complications for the mother and the baby. They add other risk factors as they refine their risk score. And actually, I want to tell you, this is available in the internet. You just need to look at CardPreg 2 risk scores, and you can put your patient and personalize. Okay, so the patient had any cardiac event, do the patient had any arrhythmia, and you will get a score. What is the New York Heart Class function class? Is the patient doing the daily living or not? Is she having shortness of breath? Is she not able to go for a walk? Those kind of things will help you to classify the functionality of the patient. Is the left heart have an obstruction? Do we have a systemic ventricle dysfunction? Mechanical valve, pulmonary hypertension, any history of arthropathy, any history of prior cardiac intervention, and also when the patient was assessed during the pregnancy. Do the patient had a late pregnancy assessment? Also got that. And you can see how it give you a value that you can go and assess your patient and counselor, is this pregnancy going to be a high risk and how such? And this is now being available in the internet. You can do your own personalized assessment. The other risk score that we use that's very important is the modified WHO that looks at moderate systemic ventricular dysfunction, ejection fraction between 40 and 45, look at systemic right ventricle dysfunction, patients that have spontaneous circulations, cyanotic conditions, aortic dilatation, most common, such as Marfan, so critical regions dilatations of the root, from 40 to 45, or 4 centimeter to 4.5 centimeter, or by cuspid aorta, where the critical risk for dissection is 45 to 50, or the incident to have a mechanical valve that requires full anticoagulation. Here is the table, it's readily available on internet, and you look at your class from 1 to 4, and pregnancy is definitely contraindicated at the time that we look at classification 4. For classification 3, it's definitely a decision shared with the multidisciplinary approach. I want to take a minute here, and I want to make sure that everybody is following me. I'm going to be switching gear, although with this disconnection, I'm sure you're being on your toes. I want to emphasize that really to take care of these patients with cardiac conditions and their baby, it takes a village. And I only have the privilege to have that opportunity here at Stanford, where we have a multidisciplinary approach to these very complicated pregnancies and delivery. Much more has been shown in the literature. Some of that I have been sharing with you through the CMQCC, and these toolkits in cardiovascular disorders and pregnancy is available. You can just log in the CMQCC and you will find these toolkits. The American College of Obstetrician and Gynecology had a joint clinical managed guidelines with cardiac folks as well, where you can refer. Very comprehensive pregnancy and heart disorders, and it really helps you to dissect it by condition and what is advised to do. There's many literature coming up looking at prospective multidisciplinary studies to really take care of these pregnancy outcomes and creating multidisciplinary pregnancy heart teams. So the heart team should be a combination of people like me, maternal fetal medicine, high-risk obstetricians, cardiology, and cardiac anesthesia as a minimum. So we can really offer the patient a multidisciplinary approach. We really want to see clinical consideration and recommendations, if possible, before pregnancy, to do this more in preparation for pregnancy. At Stanford, we have, in the LPCH, we have a very comprehensive approach where we have cardiology, we have arthropathies, we have pulmonary hypertension, electrophysiologists, many other cardiac genetics, CT surgery, or neonatologists to really help us to achieve this goal. I want to take you a little bit through what we have studied and what we have published. We started to look at these patients. We are being taken care of, and this program has been going on for well over 10 years. So we started looking at our own experience as a way to really put the information out there. We looked at the care of pregnant cardiac patients and look at the effect to have a multidisciplinary approach in collaboration with many colleagues here at Stanford. This paper specifically really looked at the demographic of the patients and the different disorders. As you can see, we take care. Arrhythmias, patients that have pacemaker dependent, ventricular septum defect, which is the most common congenital heart defect, ASDs, dilated cardiomyopathies, aorta regurgitation, any cardiomyopathies, mitral stenosis, other type of congenital heart defects such as tetralogy of Fallot and transpositions of great arteries. And we looked at the obstetric outcomes. We wanted to understand about these patients, what was optimal obstetric management, looking at how many of those were successfully achieved vaginal delivery versus a scheduled C-section, and so what of those developed common obstetric things that are complicated by premature rupture membrane, preterm birth, postpartum readmission, preeclampsia. We took one more step and said, well, we want to understand the severe maternal mortality markers. CDC had come up with 21 indicators here enlightened to you. And we asked that question in this small prospective cohort and that we're following. 15% of these patients develop a cardiac event, pulmonary edema, arrhythmia, cardiomyopathy, acute heart failure, or stroke. And about 12% of this cohort, we saw that they experienced severe maternal SMN, severe maternal morbidity, for what we really pay attention. Because the nature of our cohort just being here at Stanford and single institution, we really wanted it to branch out as SMN is such the severe morbidity is such an indicator that you need big numbers. So we look at the California birth rate data set, and this is what we found. We found that cardiac disease prior to pregnancy strongly is associated with SMN, especially in cardiac event. As you can see here, you have pulmonary SMN, cardiac SMN, hemorrhagic SMN, renal SMN, and you see how cardiac SMN is so representative, calling for continuing having this multidisciplinary approach. What about mental illness? As you can imagine, we are experiencing quite a bit of burning from mental illness in our pregnancy cohorts, more if you have a cardiovascular implication. So we really wanted to understand the implication of mental illness in this very susceptible group. So we looked at depression, and we'll look how depression and preterm delivery sort of like it's a two-strike in this patient population, an increase of depression and an increase in risk of preterm birth. So something that we are actually working to understand better and to support better our patients. We have a perinatal psychiatrist, we have social work, and we also have therapists to really offer this patient a whole comprehensive support during pregnancy and postpartum. But let's take a quick look at our neonatal outcomes in this patient population. So pregnancy complication will have the maternal and the fetal diet. So we know, as I've been explaining to you, maternal cardiac event is common. We can see heart failure, arrhythmia, stroke, cardiac arrest, and unfortunately death. How about the baby? So babies do have also complication. We see an increased risk of prematurity. A lot of the premature birth is indicated. So is our medical recommendation, but some of them are spontaneous preterm birth. We see an incidence of small for gestational age, babies being born with respiratory distress, and even neonatal death. For small for gestational age, I just want to also put in a little bit of context. So if we're talking about congenital heart disorders, mothers versus acquired. Some of the congenital heart mothers, more the Fontan circulation. For some reason that we are actively investigating research, they tend to have an increased risk to have a small baby. We don't know, we're not sure if the chronic cyanosis and hypoxia can lead to that, or is it part of the phenotype of having born with a Fontan circulation. So a study in Canada was very interesting, looking at over 1 million women that had this longitudinal cohort analysis, and they had congenital heart defect in their offspring. And they used as a window opportunity to understand the other counterparts. So now we're looking at the babies with congenital heart disorder, being somebody that's actually say, hey, if you have a baby with congenital heart disorder, you should look at the heart of the mother, because mom also can have a undiagnosed heart defect. So that's one of the calls that this study, very important. And also call for like women who have given birth to those offsprings with congenital heart defect might benefit for early attention in cardiovascular risk, because they might have their own risk factor. We wanted it to look as a continuation of understanding the diet, understanding the neonatal outcomes. We look in our own prospective study, about 466 pregnancy. If we wanted to understand if receiving a multidisciplinary care, maternal fetal medicine, cardiology, OB anesthesia, cardiosurgery, geneticists, in a single tertiary center as Stanford, would it change the outcomes in our maternal congenital heart cohort, maternal acquired cohort, as compared to other cohorts that had no cardiovascular problem? Oh, sorry. Not today. Okay, so what do we saw? Here's the maternal demographics. You can see that we have more or less a distribution equally for nulliparous versus multiparous. The delivery mode was an increased representation in both groups for cesarean section, congenital and acquired. For maternal race and ethnicity, you can see the distributions here. When we looked at birth weight, in red being congenital heart disorders, in blue being our acquired, and black being our control group, we see a slightly decrease in the birth weight, small for gestational age. We also see a little increase in the NICU admission, more for congenital heart defect mothers. And the length of hospitalization was similar for acquired. With regard to small for gestational hair, you can see here a neonatal death. We definitely saw a significant increase in the maternal congenital heart disorder cohort. In summary, we like to conclude that maternal heart disease are associated with more adverse neonatal outcomes, necessitating a multidisciplinary approach. I cannot emphasize that, to really tailor strategies for this patient population. We also looked at this small for gestational age that we really want to research in the future to see if it is a part of the phenotype from congenital heart mothers. As in the same train of thought, on trying to understand maternal health and maternal as a whole, psychological affection, we conducted a study looking at adverse childhood event in these patients. We look at this cohort and we wanted to really understand, had been exposed to ACE, adverse childhood event, how that could represent greater complications. And we, as you can see here, we saw an increase of incident for fetal growth restriction in patients that showed to have more elevated scores when they were screened for ACE during the prenatal care, as you can see in these pictorials. One of our medical students really wanted it to ask further questions about what happened after the patient delivered, what happened during the fourth trimester, and how this very highly complex cardiac cohort would feel after having babies. So we conducted a mixed method study, quantitative and qualitative interviews on this prospective cohort. And we wanted to understand what was their impression after going through a pregnancy and a delivery. And here you can see how about 83% of the patients during the postpartum visit say that they would like to have more often visit with their OBGYN during pregnancy and postpartum. And they definitely would appreciate being seen within a shorter interval after delivery with about 2 weeks. In general, if you have a vaginal delivery, you see your OBGYN about 6 weeks after delivery. And if you had a C-section, you sometimes see you by 8 weeks. So these patients definitely say that they will appreciate it a sooner appointment, and they also will be okay with have alternatives, sort of like telehealth or have a home visit. So this is more data that comes from our core that has informed us and help us to understand better these necessities in a very particular cohort. So switching gears a little bit, I want to emphasize that the best time to take care of this patient is before pregnancy. So if you're taking care of patients with cardiovascular disorders, affections, or such, it's very important that they receive a referral for a preconception. The moment that they are reproduction, the moment that they express interest to grow a family, is a good moment to start referring them to OBGYN. What we do is we really go into detail with regard to the history, the comorbidities, their mental health, things that can be modifiable. And very important in our cardiac cohort is medication exposure, because some of them will be teratogenic. So we could change and do medications with cardiology that will be not teratogenic, see how these patients do in a period of time with new regimens, new medications, and then pursue the pregnancy. I want to show you here more or less what is our workflow. We, in the maternal heart program, we get patient referrals with consultation with maternal fetal medicine, cardiology, obstetric anesthesia. We hold monthly multidisciplinary reviews of the patients and fetal status. We have a consensus-based care plan. This gets uploaded in their electronic medical record, and then a delivery and a postpartum plan with contraception plan gets integrated. Here to the right, you will see our sheet. I'm happy to share it. Now you have it here in your presentation. This is fundamental what we put in the EMR. Anywhere in care, everywhere where this patient presented in an emergency room, in other hospital, or in a maternity, in any given day, the patient will have a plan. It will have cardiac information, it will have medical history that's pertinent, it will have a fetal status information and a delivery plan. And this will definitely decrease an adverse perinatal outcome. What things we'd like to see as a prenatal screening and surveillance? We want to make sure that for prenatal lab, we have an understanding of the maternal compartment. Is there any evidence of anemia? Anemia has been linked to worse cardiovascular outcomes. How are we doing for any electrolytes, CMPs? How's the kidney function? How's the liver function? We want to see if any degree of renal dysfunction before embarking into pregnancy or early in pregnancy. We are acquiring more and more familiarity with BNPs by Q trimester that we combine sometime with maternal echoes to really understand the heart function during pregnancy and to early screen for any early dysfunction. Genetic risk, we look for any non-invasive prenatal testing, any family abnormality, if a patient needs diagnosis with an amniocentesis or chorionic guideline sampling. We do ultrasounds very early in pregnancy, 6 to 8 weeks to establish an intrauterine pregnancy and a heartbeat. Then they will go for first trimester around 12 weeks where we can see the embryo and looking for any signs of abnormalities. They're midway into the pregnancy, about 20 weeks, we will conduct a full fetal survey, a full anatomy in the fetus, but also we refer for a fetal echo if they are from the cohort of maternal cardiac heart disorders that were born and had corrections during the childhood, because there is an increased risk to have an offspring with congenital heart defect. And by third trimester, we really want to screen for fetal growth restrictions, so we do monthly growth. And we want to have reassurance as we have increased adverse prenatal outcomes and stillbirth. So about 32 weeks, we'll be doing weekly non-stress and amniotic fluid index to make sure baby is thriving. They will have monthly cardiology visit where they will have EKGs, echoes. It's sometimes event monitor. It's a cyto patch. If patients start to develop palpitations or any kind of rhythm abnormalities, we want to pick it up early and treat it. As I told you, number one affection in cardiovascular during pregnancy is arrhythmia. And sometimes they even have cardio MRIs to better assess valvulopathies. We like to have some kind of baseline characteristic. We want to know it's congenital heart disorder. What is the WHO classification? Do we have any prior surgical repair? What is the function classification in your heart association? Is there any evidence of diagnosis? What's going on? Do we need medication? There's an arrhythmia. And then from there, determine low risk. Let's have a pregnancy, intermediate risk. Let's do some cardiac tests. Let's get multidisciplinary team or high risk. And maybe not pregnancy, maybe start conversation. I have those conversations, they're painful, they're frank. And I talk about surrogacy, I talk about adoption and all alternatives when we don't recommend pregnancy. In summary, you could see here that it takes a village as I start my talk and take care of this patient. I'm being gladly seeing how the field has grown and how we have developed more partnership with other entities in medicine as cardiology and anesthesia. And it's been wonderful to see how the American Heart Association has made an effort to show the investment in helping us with our patients. So you can see here in this pictorial that it's important to start with prenatal counseling, then decision to make if we're going to be planning a pregnancy, what type of vigilance we have to have, what happened during the pregnancy, what is going to happen in the peripartum, immediate postpartum, and what is going to happen after the baby, how many visits, when they have to go back to the cardiology, when they go back to normal. So it does take a village. One thing I want to show, to put things in context, is very important to have a contraception uptake in these patients, have a conversation before pregnancy, during pregnancy, and after pregnancy. We did a prospective study where we really wanted it to make sure we understood what was that uptake in our patients, and we emphasized the need to, by the time they were leaving the hospital, they will have a plan. And in the interest of time, I'm just going to move and show you the conclusion of the study. We had a plan for a reliable form of contraception during the pregnancy. We saw that deciding for a long-acting contraception like an IUD or an Nexaplan, progesterone only, is a good plan. Patient had a good picked up, and it was emphasized in our data that it really achieved planned pregnancy. So in conclusion, a multidisciplinary team focusing on contraception improves maternal outcomes and decrease the chance of complications. This is just a quick showing that even working with disparities and introducing language of preference and cultural humanity increase the uptake in this patient population, as we presented in this data. So I'm going to stop here for a second. It's been a lot of a lot of material I'm giving you. I want to sort of put it in context and take a breather. Here you could see, when we look at what is going to lead to heart failure in pregnancy in this particular high-risk cohort, we have a way to approach this in a very systematic approach. You have a maternal cardiac etiology. You know your patient has cardiomyopathy, maybe dilated, maybe hypertrophic. You know your patient has maybe valvulopathy. Maybe your patient is congenital heart defect repair or not. Maybe your patient has pulmonary hypertension. What are those modifier factors that we can look into? Obesity, so weight control, nutrition, tobacco use, alcohol, substance abuse. Hyperlipidemia is very important to be addressed. And insurance. What type of insurance to really help with social determinants of health and decrease the gap of health disparity. What obstetric factors we really want to look into? Eclampsia, preeclampsia, hypertension disorders, any abnormality in the placenta. What comorbidities you want to keep an eye on it, and how they contribute to the patient adverse outcome. What non-modifier factors we have? Black race, age, anticoagulation use. All those are things that we have to put in the balance to really decrease the chances of either having heart failure in this very high risk population. Looking at the other compartment in neonatal outcomes, we want to keep an eye on having these multidisciplinary meetings and keeping an eye on birth weight, and other complications to decrease the prematurity and the mortality in the counterparts neonates. In the winter issue of the Stanford magazine, you have future very interesting approaches now with 3D printing, with the ability to use for research constructing parts. And so that's why I have this cartoon if I only had a heart rate. And, you know, in the near future, perhaps this research will be transcended to the point that we can build organs and build a heart for these patients. But I wanted it to bring it up because one of the things that is always challenging in this new field is that patient with congenital heart disorder or acquired cardiac problems historically sometimes will not achieve pregnancy, or they will have so many complications in pregnancy that perhaps they will not have more than one pregnancy. And now these days, with medicine, surgery, and all kind of medications that we can utilize, and all the multidisciplinary approach that I've been telling you, it really helps to support these patients to have their desire to have a family. But then I'm always in these difficult conversations with the patients when we talk about it, what this would represent to these particular patients as lifespan. Is pregnancy actually decreasing the lifespans of these patients? And as I told you, pregnancy is a wonderful opportunity for have a cardiac test, like a stress test, but it's also a wonderful window opportunity to the future where if we see an increased BMI, we can work with nutrition and postpartum of a target to have an ideal weight. If we have a smoking, alcohol, and drug abuse, it's a great time to help to the patient to stop that. If we develop preeclampsia or hypertension disorder during pregnancy, we know 10 years down the road or more, patients are going to develop chronic hypertension if lifestyle intervention doesn't happen. If we see gestational diabetes during pregnancy, we know the same will happen and patients will acquire type 2 diabetes. So it's a wonderful window opportunity for the future. So in particular, in this context, in patients with cardiovascular affection and congenital heart defect, I always thinking what pregnancy really does to the lifespan. And I don't think we have an answer yet. And more research I'm going to show you are trying to start understanding how aging affects this population, but also how we can age with grace now that it's projected that perhaps we will live for over 100 years old. So I like this quote from John Lennon. It said, "Count your age by friend, not by years. Count your life by smiles, not by tears." Thinking about things, biomarkers, biological things that we can look to can help us to understand better the effect on aging. Telomerase have been something that is widely studied to really understand the cell span. And what they are the DNA caps at the end of chromosome that shorten with cell division. Shortening could be accelerated by stress, and it has been shown, which is more interesting, that it could be reversible with life intervention. So short telomeres is sort of like thinking about if you have these sneakers and the threads are started to open and then they just unravel, and then you end up not being able to use your shoes. So same for short telomeres. It's early morbidity and mortality, and it's a cumulative effect from biological effect stressor. So we investigate that in pregnancy, and we have few publications on it, and I hear the reference, and we saw how inflammation and psychological stress can really short the telomeres and can short the lifespans, and we saw it in pregnancy as well. I'm studying actively aging and cellular aging, so other biomarker that we knew recently are also looking is what we call the methylation clock. And this is a biomarker for aging that is more related to epigenetics, so more your environment, because it's related to the expression of your methyl groups that actually would decode or not decode genetic information depending on environmental exposure. So really understanding the biological aging mechanism in pregnancy, it might inform us really how to risk reduction these estrogens. Here in this cartoon, there are many things that, and I'm not gonna dive a lot in what is the gene translation and transcription, but you can see to the left how DNA methylation plays a role for that transcription really happen through our genome. So through epigenetic exposure, we can see how this methylation clock could help us to understand the difference between biological age versus chronological age. And the thought is that perhaps you're 40 years old, but you have a very good a medical history from the point of view that your BMI is within range, you're not taking any medications, you don't have any comorbidities, and you exercise 5 to 6 days a week and have no health problems, versus somebody perhaps is in their 20s and is in type 2 and you have an increased BMI, and how that really compares with your biological age. And that's why we're trying to have biological markers to really help us to understand better the difference with chronological age. So applying this concept to our maternal cardiac cohort will help us perhaps in the future, help us to consult these patients when they ask us about what happened to my lifespan if I endure a pregnancy. We have many collaborations here at Stanford. We're very fortunate to work with the Maternal Child Health Research Institute, with the Living Maternal Fetal Center, with itself the Fertility and Reproductive Health at Stanford, and the 17 Lab, when we are conducting right now these experiments. A lot of these experiments are going to be presented next week in the annual meeting in the Society of Maternal Fetal Medicine, where we've been trying to understand the effect of preconception epigenetics through aging, looking at the incidence of live births and pregnancy complications. We're using surrogates of these methylation clocks through PRC2 age index. We're trying to actually validate these different epigenetic clocks in pregnancy, as we don't have a really standard. And we're looking at longitudinal changes of this epigenetic aging in pregnancy versus no pregnancies. So that's the future, and that's how I could tell you that we are going to try to pivot to our high-risk cardiac cohort to really help to disseminate information and really to be able to counsel appropriate our patients. Couple of slides I wanted to put out there for you as a reference, because I think it's important to look. It's a recent publication from Circulation Research, where looked at women and cardiovascular health, looking really what the reproductive risk factors are out there, not only pregnancy, but reproductive risk factors since breastfeeding, menarche, ovulation, and then menopause, represented in patients with regard to cardiovascular disorders. And what is important to really bear in mind is that the field of menopause is right now exploding. It's not just about aging and all the affections and menopause, but also with regard to chronic disorders and with regard to our cardiovascular system. So I wanted to put a couple of slides about after reproduction having fulfilled, what happened to our patients getting into the 4th, 5th, 6th decade. So I wanted to just have one slide looking at what it means menopause and hormone therapy. And as you know, things are changing in the field from the point of view that we are getting more and more data reassuring that actually the number one killer after 50 years in female population is cardiovascular, not breast cancer. Breast cancer will get to you. Therefore, we have to do an assessment and an informed sharing decision with our patients to really help them to go through the transition of perimenopause and menopause, and at the same time trying to decrease that cardiovascular risk. So things that are sort of like in these traffic light green lines for patients considering to the hormone replacement therapy is to think about recent pause, normal weight, normal blood pressure, physical activity, an assessment for cardiovascular risk less than 5%, and have low risk for breast cancer. Then we have in the yellow zone where you have to really think about it and have a very concise and complex conversation with your patient with regard, like if you have comorbidities as such, diabetes, smoking, hypertension, obesity, sedentary life, autoimmune disorder, hypermethylemia, metabolic syndrome, all those kind of things would increase your chances of cardiovascular risk over 10% and high risk for breast cancer if hormone replacement therapy is a good idea for you or not. And then we'll be in the big stop red line where you'll be high risk, and people with breast cancer, people with already stroke, myocardial affection, people in the group of congenital heart disorders might not be the best or pulmonary embolism might not be the best candidate to be exposed to hormone replacement. And those were a couple of slides I wanted to put out there for you to have as a reference and beyond my areas of expertise, full disclosure, but it is something that I want to start thinking about, and you guys, I would like for you guys also to see what happened after our patients are no longer in reproductive age and they had succeed the desire of having a family. With this, I want to leave you with my gratitude. I want to leave you with my email. I'm an open door. Please email me for any questions. If you want to chat, if you want to collaborate, we are conducting many research studies that I'm trying to illustrate here. This is a new field, and we definitely are here to advocate for our patients and for their future pregnancy and offsprings. And it's as you can tell, it's a lifelong commitment. So come and partner with us. We have here questions. If anybody wants to provide any question or comment, we have time. So please let me know.
Thank you, Dr. Bianco. We have quite a few questions. The first is there a predictable pattern of non-pathological elevation of BNP in pregnancy and postpartum?
That's actually a very good question. So I would say early on when we started studying these patients, BNP was sort of like not a straightforward indicator because the data come from patients that are not pregnant. We have becoming more and more familiar with this molecule in pregnancy, the more that we have been investigated and the more that we actually honestly obtaining, and that's why I like to have it by trimester, because at least I have a curve I can follow. Studies have shown that you really have elevations in your BNP. We're talking about over 600, 800, even to 1,000. Those are numbers that have to give you a pause. You know, a little leak, a little 50, 100, 200. It might be just part of the pregnancy physiology, and as I told you, the circulatory system adapting to pregnancy from the first trimester to the second trimester, that very sharp peak, and then going to the plateau and then phasing the delivery. So it might be a little bit of BNP leak in that way. So you have to put in context of your patient. But when you see quite a bit of representation, it might be an indicator that you really want to follow with cardiology. You want to get an echo and make sure that you don't have any diastolic dysfunction.
Thank you. Our next question is, how are we defining obesity in pregnant women? There are new articles dividing it into preclinical and clinical obesity.
And that's a good point. I think you really want to standardize your patient by pregnancy and not pregnancy. We definitely like the pre-pregnancy assessment and have that opportunity before pregnancy. When the pregnancy is achieved, we just go by the BMI, and depend on the target of the BMI, we will recommend a weight gain, and it's very well, supported by the Institute of Medicine.
Thank you. Our next question is, have you investigated whether or not results related to depression, desire to have more OB visits, postpartum, etc., are impacted by having a doula?
I love that question. We definitely, in another other type of project that we do, and we are definitely exploring the possibility of labor support, doulas, but also pregnancy support. Definitely, we know mental health is becoming an epidemic in our patient population, pregnancy and postpartum. We've seen way too many patients with anxiety and depression. Some of this was sort of spike after COVID, but it has been maintained. And we know biological reasons due to the fact of all these hormone changes and women's is really a roller coaster, but there's also to be said about the environment. So definitely there are the studies and there are interest to really partner more and more with these type of patients, supported, if you will, with doulas. There are studies coming from Massachusetts, from Boston City Metro, where they have been able to have this community support and community outreach, bringing doulas to the birth and bringing doulas to the prenatal care and to the postnatal care, and how that's had increased patient satisfaction and adherence to medication, but also to improving the mental health. Here at Stanford, to be honest, we are creating a more comprehensive, I would say, program in mental health. So as I mentioned, we have a dedicated psychiatric and for our practice dedicated for mental health in pregnancy and postpartum. We have therapists and we have social work. We also have implementing something that's called centering in pregnancy that has shown patient satisfaction and actually help with mental health as well, meaning that patients can be in a group and taking care of the pregnant or her prenatal care in a group of 6 to 10 patients. They get educated, they get empowered through the process, through what is being pregnancy, what aspect to my pregnancy, how to own my delivery, what type of support I need during my delivery and postpartum. So centering has become another arm to our mental health support. But yeah, definitely doula program is something that we're thinking about. Thank you for the question.
Thank you. The next question is, do some of the patients deliver in the ICU with vasoactive drips with invasive monitors? How does this impact NICU staff, equipment, and resuscitation?
Great question. So lately, if you read in the ICU literature, the idea is to bring the ICU to the patient. Here at Stanford, we have a little bit of complex dynamics as we are two different hospitals, if you will. And a lot of medical centers have this situation where obstetrical care is under the children's hospital and the adult care is under adult hospital. So when we have a maternal cardiac patient, there are times that patients need to be in a cardiac unit. Therefore, their care has to happen in a cardiac unit. However, we definitely consider highly the separation between mom and baby. We believe in that bounding. Therefore, we're trying to bring the ICU to the bedside, meaning we have the opportunity to work with intensivists and with cardiologists and LV anesthesia, cardiac anesthesia in our unit, in our labor and under unit. We have 24/7 telemetry, heart monitoring beds, and we trying to achieve that. However, patients that need to be in IV trips, and we consider that they're extremely high risk, who have to go to a cardiac unit, which is not in communication with the children hospital. So what we do in those cases is we're trying to really honor after delivery the baby to come to bedside to mother, and trying to optimize mother care as much we can to bring it back to our unit.
Thank you. Our next question is, any insight on pregnancy issues for women with postural orthostatic tachycardia syndrome or long QT syndrome?
So we have quite a bit of patients with POTS and with prolonged QTs. I would say it's not fun to be pregnant with those conditions, but we do work with them and we definitely trying to support them as much we can. The changes in pregnancies dynamics and the changes in your gravity center, your center of gravity is such because your uterus is getting outside your pelvic bone and it's moving forward, and you're really creating such a changes in your gravity centered. It makes this pregnancy very challenging for our patients. So we definitely take care of them. We see them very periodically. We're trying to work with their hydration and their blood pressure. We work with neurology and we work with cardiology to try to optimize the circulation. But it's definitely a journey for those patients, and we take care of them in a routinely basis.
Thank you. Our final question is, does preeclampsia in pregnancy just show the increased risk for CVD later in life, or the disease burden of preeclampsia causes an additional negative effect on CV health?
Very interesting question. What is first, the chicken or the egg? We think, and pregnancy has been investigated in many ways: autoimmune disorder, inflammatory, infections, cardiovascular, you name it. Preeclampsia is such a conundrum syndrome. What we know is that if you experience high blood pressure during pregnancy, down the road, if lifestyle modifications are not in place, you will develop chronic hypertension. There might be a subset cohort that is genetically predisposed to have high blood pressure, and it will be expressing high blood pressure early because pregnancy accelerates the phenotype expression. So it's not a one answer fits all. This is more where personalized medicine goes in. But we do know that when that is a window opportunity to check your lipids. It's a window opportunity to, if I still have high blood pressure after my delivery, to get a meds and to look at DASH diet, Mediterranean diet, low salt diet, intervention that really has shown that modified your cardiovascular risk, establish care with a doctor, all those kind of things. So it's a wonderful time for intervention.
Thank you so much. That concludes our questions. We want to thank you for your participation today, and to our audience, thank you for joining in.